Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.
Hi, I'm Sherry Harlan, program host for Let's Talk Together. And today, our guest is Dr. Ted Kostiuk with our Reid Health Comprehensive Bone and Joint Center. So welcome, Dr. Kostiuk.
Hi, Sherry. Thanks for having me.
Also, just for clarification, he's going to be Dr. K for the rest of the show. And so before we get started, tell us a little about your background and how you came to Reid.
Well, Sherry, I grew up in the Chicago area and did all my medical training there as well. I had a practice before I came to Reid, about 6.5 years in Michigan, and then wanted to move to a smaller community and kind of get away from the city, and chose Richmond for a lot of reasons. It's a great city. My wife and I came down to visit. We really enjoyed our time here, and also Reid. Once I saw the hospital, the facilities, I met a lot of the employees and other physicians. I was strongly attracted to come here and start my practice.
And I have the pleasure of being in the community. I've seen you and your family at various community events. So you definitely fit into our community.
Oh, well, thank you. We appreciate that. Yeah, we have 3 young girls who are in school, and we love living here. It's a great place to raise a family.
Oh, great. Actually, so today we know that you're a spine surgeon?
That's right. I'm board certified, fellowship trained orthopedic spine surgeon. So that means it's an orthopedic residency and then a spine fellowship after. And now I specialize in surgery of the spine, primarily degenerative community spine. We do what most normal community surgeons do. That's myself and Dr. Vienne and the rest of our team. We have 3 PAs or physician assistants that also see patients with us. So we have a great team working together, as well as our ability to get patients in pretty quickly because of the number that's on our team. So I focus primarily in doing surgery on folks who have disc herniations, things from just run-of-the-mill arthritis and degeneration that we all get once we get into our 30s, 40s, and 50s.
So tell us so our viewers can understand just an overall approach to spine care. Can you expand on that?
Yeah, of course. My general approach to spine care is that all spines are unique, and not everyone needs or has to receive the same treatment. So when you come see me in my office, we have a conversation about how long you've had pain for, if there's any neurologic signs, that means numbness, tingling, or pain, weakness, and how long those things have been going on for. We talk about the treatments you've had in the past, if any, whether it's been any conservative treatments, things like oral medications that we all start with when we have a sore back, whether it's Tylenol or ibuprofen or those kinds of things. Because generally speaking, most spine injuries or pain that we have is self-limited and it's from a strain or a sprain and arthritis. So my philosophy is to treat everything conservatively first, and then surgery is always the last option.
So how do people, are they all referrals? Do they go through their primary care to get to you? How's that work?
Yeah, that's a great question. People often think they need to have a referral. That can happen, obviously, if you're seeing a regular doctor and you're having issues with your spine or your neck or having weakness or numbness or tingling in your arms, your legs, they may send you to see us. But also, if you're having those symptoms, you can always come to we have an urgent or a Reid walk-in for our ortho walk-in clinic that's located at the same location on Highland Avenue. So there's times where you can get in and see us the same day. It just depends on how severe your symptoms are. If we have an opening, we try and get you in that day and see you.
because that was going to be my next question. I was going to ask, do you receive people from the walk-in clinic?
Definitely we do. And that happens on a daily basis. Either myself, Dr. Vian, or one of our PAs are usually available in there in the office on a daily basis each day of the week.
The other thing, so in case a person needed surgery, and walk us through that process.
Sure. So the things that we look at for surgery, the most common reasons why we get to that point are those patients that failed conservative care. So they've done all the things as far as physical therapy and tried medications, maybe an injection, seen a chiropractor, done home exercises, tried pain patches and whatever else that they saw on TV. And if they get to the point to where their pain's uncontrolled and it's affecting their activities of daily living every day, and they have more bad days than good days, I usually will see them in the office and counsel them based on what I see and say, this is what I think the right surgical treatment is. The other reasons why we would move on to surgery sooner rather than later are any things like that we call red flag symptoms. So if someone's having progressive numbness, tingling, weakness, loss of bowel or bladder control, and those kinds of things, or spinal cord dysfunction, that would be spinal cord compression, tripping on your feet, falling, dropping things, not having good balance. Those are all things that we hear, and it makes us want to get an MRI or move the surgery more quickly. But those are rare cases. So once someone gets to the point that we think they need surgery, we would work them up in that regard, either starting with x-rays first or an MRI, depending on their symptoms, and kind of go from there. And we take each patient and their symptoms and their imaging and treat them separately. Like I said, I think that every patient deserves tailored treatment to make sure that they're getting the right care at the right time.
Looking at, for instance, what about inflammatory? I'm sure, especially with arthritis or whatever, do you get referrals through for inflammation?
Yeah, for sure, definitely. As I said previously, the most common reason most of us have neck or back pain as we get older is from inflammation, either from a sprain or a strain, or from lifting up a heavy box and just causing some pain in their back or in their neck. That's the most common reason we see people every day in the office. It's probably 2/3 of the patients that I see. And most folks that I see in the office, 90% don't need surgery. It's about 1 in 10 patients who I see that we end up having to do surgery on them. So 90% of people that come see us, whether it's a disc herniation or an inflammatory problem, the majority of those can be healed with conservative care.
If you're seeing just various lifestyle changes, or what's some lifestyle issues that they might need to come see you?
Yeah, for sure. These are all things that we work on. Once we see it, we talk about things that can influence your back and spine health. Posture is important. People ask me about posture all the time. Is that over time that can add some extra wear and tear to your spine and cause pain and degeneration if we're in a job where we're lifting often and not using the right lifting techniques to help preserve our back function. That can cause an injury, a sprain, a strain, or a disc herniation, and all those things can lead to problems down the road.
So, if a person has, especially when you're saying with the back issues, that the strain or the sprain, so that would be a cause where they could do more physical therapy as opposed to actual surgery?
Almost definitely, yes. Is that those patients will typically get better with things like physical therapy or chiropractic care or medications like anti-inflammatories or steroids, maybe nerve medications sometimes if there's some nerve symptoms. But we will move towards surgery if those things fail or if someone's having those neurologic signs that I mentioned before.
And then, once again, so when do we consider seeing you once again?
Yeah, so the reasons for that we usually say you should see a surgeon are if you have those similar symptoms I mentioned, those red flag symptoms, persistent numbness, tingling, pain that's uncontrolled with conservative management, or especially weakness, falling, dropping things, those kinds of things. That's a reason to come see one of us. If you move towards surgery and we're going down that path, surgery has changed a lot in the past 20 to 30 years. Just the techniques and methods that we use now are a lot less invasive or minimally invasive is a different term that you can use to describe it, as opposed to traditional open surgery. So once we move towards that, we try to find the right surgery for your problem.
So then they would need, explain to us about the diagnostic process.
So typically, if you haven't had them yet, when you first come see us, we want to get X-rays because we want to look at the alignment of your spine. If there's any instability, perhaps a fracture or a break in one of those bones that can happen after a trauma or a fall. If you're having any neurologic symptoms or you failed conservative care, we move past an X-ray and get an MRI, usually without contrast, so we can see the discs and the nerves and see if there's any compression on those nerves or on your spinal cord. The most common things that we see in the neck are things like disc herniations that cause, again, pain, numbness, tingling, or weakness in an upper extremity in your arm, or in the low back. It would be similar to, for one of your legs or both arms. If we see those things on the MRI, we would plan a surgery based on where that herniation is and where or what nerve it's pushing on, because the treatments change depending on where the issue is within your spinal canal or neuroforamen, which is where the nerve leaves your spine to go to your arm or leg.
Can you give me an example of something that's changed?
Sure, of course. The thing that's changed the most probably in spine surgery is that in the low back or in the thoracic spine, the middle spine, is that typically in the 90s and even the 80s and early 2000s, a lot of surgeries were performed open. And those surgeries did a great job. And the issue is that they did increase the time it took for folks to heal after surgery, and there could be a lot more pain afterwards. We've now moved towards less invasive techniques where we can use technology to be more specific and precise in where we're doing those surgeries. For example, a lot of lumbar surgeries that I do nowadays, I either do them with a tube, meaning a small 2-centimeter diameter tube to do a discectomy or a decompression surgery for someone that's a disc herniation. And I can use that same tube plus our stereotactic navigation system that we use to help localize and place instrumentation or screws into your spine more in a way that we can use smaller incisions and not have to open your entire spine to see it to do that surgery. And that's made recovery a lot faster. People have a lot less pain after surgery, and we think down the road will show is less likely to cause more issues with the rest of your spine as you age.
And along with the diagnostics, the imaging and the tools that you use?
Yeah, I guess the one I didn't mention is we also can get CTs of your spine, and we use all three of those modalities, X-ray, MRI, and CT to help plan our surgery. If we're using that robotic navigation system I mentioned earlier, what's nice about this newer system is that we can plan the exact location and trajectory of the implants in your spine on that CT exam before surgery, and then reproduce that confidently in the operating room over 99% of the time. So we're a lot more accurate and able to produce the results that we want to get, whether it's to realign your spine, whether it's to decompress those nerves, or whether it's just to relieve pain.
Common diagnosis.
Yeah. As I mentioned before, the most common two things that we see first are sprains or strains. And then we see next, typically, as all of us age as humans, we do have some arthritis, just like in your knee or your hip. You get that in your spine. In the spine, the arthritis is a little more complicated because at every level, meaning if most folks know we have 5 bones in our lumbar spine, L1 through 5. We have a disc between each one of those bones, and then 2 facet joints in the back that support our spine like a tripod. And all 3 of those areas can wear out and cause issues where it can cause pain if it's just from the arthritis, or it can cause neurologic or nerve symptoms if those arthritis spurs grow, or you have a disc bulge or herniation. So those are all kind of related in that regard. We can see things like broken bones or fractures, or someone falls at home on a step or off a stair, and those can require surgery or stabilization either with cement or with screws and rods. And then we can also see disc herniations in the cervical spine, where they may require typically one of 3 things to happen, whether it's a disc replacement to help preserve motion in the front of our spine, or a fusion depending on how much arthritis is present at that level, or even a small decompression in the back of the neck called a foraminotomy.
Okay. And along with that, the treatments that go with that, with the like the spine compression or whatever, there's specific treatments that are done.
Before surgery, is that what you're asking? So before we attempt any surgery, again, we're going back and saying, unless you have any of those red flag symptoms, because if you have those, we're going to take you to surgery faster. But typically I want people to try everything else before surgery if they can. Again, the general rule of thumb I use is if you're having more good days than bad and you're able to do your activities of daily living without much pain or issues, then try to avoid surgery all you can. It's always the last option in those cases. I would start with things like over-the-counter medication, talk to your primary care provider, and try some prescription medications if those aren't helping. You can try things like a brace. Bracing can help stabilize your spine, give you some support when you're active. You can try seeing a chiropractor and seeing if any manipulations or realignments can help decrease your pain. Physical therapy and occupational therapy are very useful because our physical and occupational therapists, I always remind everybody that they have a PhD in their field and they know what they're doing. I trust them a lot. So I usually trust what they say and try to encourage folks to have a good home exercise program. That matters a lot. I being now in my mid 40s, I recently had an issue with my back. I went to physical therapy for the first time. It was very beneficial for me. So I highly recommend that. And then, of course, we can also add in injections to help with control pain or decrease nerve inflammation and help control those symptoms to try and get you better without surgery.
What are some surgical goals?
Yeah, so in surgery, our main goal is there's two things. And I tell my patients in the office that in general, that there's two things that I can do in spine surgery. Is that I can take pressure off your nerves or take pressure off your spinal cord, and then I can stabilize bones that are unstable. Sometimes those bones are unstable from arthritis or degeneration or from a trauma, like a broken bone, or sometimes they're unstable because we make them unstable as surgeons to try and make space for your nerves or spinal cord. So those are our two main goals. And the ways we accomplish those vary depending on what we see on your imaging and what your symptoms are. So if someone has instability, for example, they have something called a spondylolisthesis. That's a word that means spine slip, where our bones actually get loose as we get older. That's a common cause for folks to have low back pain or pain radiating into their hamstrings or legs, or even causing weakness in their feet. We would want to first of all stabilize those bones because they're unstable. That's what's causing the symptoms. Right. To do that, we usually place something between them to help lift them back up again and restore the height of that disc from when they were younger. And then once the height is restored, we stabilize them with screws and rods in the back. Other common things that we see are folks that have a bad alignment, whether it's a degenerative loss of curvature in their spine. We're supposed to have something called lordosis in our neck and in our low back, and that's the backward bends that we all develop when we're young. That tends to go away as we age, and we all get a little shorter because our discs get less tall. So we sometimes have to restore that alignment, and that can take different implants, whether it's a spacer between our bones or screws and rods in the back to help do that.
Also looking at the surgical side, the planning, and could you share with us some of the planning and the techniques?
Yeah, well, typically nowadays, that goes back to what I said before, is that we use a lot of surgical programming aids using an MRI or a CT and X-rays to measure your alignment, whether it's too forward or too backward to the side, like in scoliosis, and try and restore those parameters back to anatomic or near anatomic ways so that we can make you have less pain and stand up straighter. But we can use those tools like our robotic navigation system to plan your surgery very precisely, so that if someone needs 10 or 15 degrees of restoration in the angles of their spine, we can do that. We can put those implants into the system with your imaging, and we can even make cuts in your spine in that program to sort of demonstrate what that would look like once we get to surgery and show how much of a correction we can get. And then using that technology helps us be more precise.
Then with you're saying with what's one of the another of the biggest differences, because traditionally maybe 20 years ago someone says I'm having spine surgery, it's kind of like, ooh, we don't see those people for months, and now it's
That,
completely changed.
oh yeah, that's also a good question. And some of that has to do with our techniques now being less invasive than they used to be. Um, Back in the 80s and the 90s, we didn't use a lot of instrumentation to stabilize your spine after we decompressed it. We would actually have you laying in bed in a cast. Again, this is before I was practicing medicine. Okay. But we'd have you lay in bed in a cast and knock it up for 4 to 6 weeks to help that spine fuse. Now we have very powerful instruments, those pedicle screws I mentioned before, that can help stabilize your spine and allow us to mobilize you more quickly, to decrease the risk of things like having things like pneumonia or blood clots or bed sores, and get you up and get moving faster. We know that moving more quickly and getting up out of bed is better for us than staying in bed. So when you have surgery with one of our surgeons at Reid Spine, either Dr. Vian or myself, almost always our goal is to get you up and walking the day of surgery. We want you to wake up, get oriented, and we want you up and moving right away. That's one big thing that's changed, is that we didn't used to get you moving right away. And now with our more precise techniques and our smaller access that we use to find the issue, decompress your spine or stabilize it, our incisions are a lot smaller. People have a lot less pain, and they're able to get better and back what they want to do more quickly.
The within the different surgery techniques, can you share with us the like the minimal invasive surgery?
Well, again, that pertains primarily to the lumbar techniques that we use. Is that those are the ones that have changed. So well, I mentioned before that we do a tailored surgery for your exact anatomy and problem. So we do surgeries in lots of different ways in the lumbar spine. Traditionally, surgery was primarily from the back, where we made a big wide open incision, visualized your whole spine to do that procedure, and there are really good results that way. Now with the power of our implants, we can make smaller incisions, whether it's in the front of your spine, through your belly or through your side or through your back, to access your spine in different ways to accomplish the same goals with a lot less exposure, risk for complications, and risk for breakdown of your spine around those implants later. That's all. It also holds true for the neck, is that we used to be able to have to make a big incision in the back of our neck, and now we can do similar surgeries through smaller incisions to decompress those nerves. But traditionally, the most common surgery we do on the front of the neck hasn't really changed that much. Our implants have gotten better, but that surgery in the front of the neck has been the same for a long time. So a lot of those minimally invasive techniques apply more to the lumbar spine, which is more commonly what we see.
Then we're looking at cervical spine, and we looked at lumbar, the motion.
Yeah,
your motion pressing.
Yeah, I touched on that briefly, but those are all newer. That's all a newer field that we're moving towards in spine surgery. That what we see in medicine is that there's the pendulum swings different directions over time, and we attempted to do a lot more motion preservation in the early 2000s, but initially the results weren't turning out that well, so we moved away from it for a while. But now we're moving back towards that again, especially in the cervical spine. Just like you have your knee or your hip replaced, we can do something called a disc replacement in the cervical spine and the lumbar spine, cervical disc arthroplasty or lumbar disc arthroplasty, for patients that meet certain criteria. And generally speaking, it's a younger active patient that doesn't have a lot of arthritis or degeneration in their spine, and primarily has pain from the disc or has a disc herniation only, that's pushing on a nerve, and the rest of their spine typically is normal per se, or the alignment's normal, so we don't have to worry about any excess stress on those implants. But we think that's the future of spine surgery, is moving towards more motion preservation as opposed to fusions. I think we're going to see a lot more of that in the future, and I definitely am moving more towards that in my practice as well.
What are some of the risks or complications with any kind of spine surgery?
Well, spine surgery is major surgery. I always tell my patients is that it's never a small undertaking. So the most common thing that I tell my folks, or the patients that I do surgery on, is that like I said, there's two things that we're good at doing in spine surgery: taking pressure off of the nerves and spinal cord, and fixing instability. As far as anything else goes, having back pain from arthritis. Some people see it as a complication, but back pain's common after spine surgery. We can't fix back pain. That's why we've moved away from telling people that we can fix their back pain like we used to do in the 90s and the early 2000s. And if you talk to those folks from back then, a lot of them had surgery for back pain, and you ask them how they did, and they said, I still have a lot of pain, the surgery didn't help at all. So I would say the biggest thing to worry about after surgery is still having neck or back pain. But in general, the risk of those other complications, the ones that I would consider rare, things like nerve damage or bleeding and those types of things, are very rare. They're only they're less than 1% chance of those things happening overall. So we always touch on those things when we're talking about surgery, but we don't see them very often. And that has to do a lot, I think, now with our more precise, less invasive techniques.
Well, as we wrap up, what's something that you would like your patients and future patients to know?
I want people to understand that coming to see us doesn't mean that you're going to have spine surgery. Is that we're going to find the right solution for your problem, or find the right surgery and tailor that to your anatomy or what your issue is, and not to worry that you're in good hands. Is that we're gonna take care of you and try and get you back to doing the things you want to do, so that you're not limited by your pain or limited by your function. We want to get you back to a good functional life, and because we all want to keep living and doing the things that we want to do, and that's the most important thing.
Okay, and thank you, Dr. K.
Of course.
And thank you for joining us on Let's Talk Together.
Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.